Hepatic encephalopathy is a serious neurological complication which is caused by liver disease. It's neuropsychiatric, it has motor deficiencies, and it's something that's very debilitating, which has a lot of impact on the patients for sure. So as indications have demonstrated, lactose is primarily the first line of treatment, and then rifaximin comes on board as second line after they've either failed to respond to lactose or they've had a second episode of hepatic encephalopathy. I think right now, I don't think there's many options for the clinicians in hepatology, and I think there's a lot more need for new treatments. And I think an ammonia lowering strategy, that's something that's really shown to lower ammonia, would be something that's really needed for this population. If you look at hepatic encephalopathy, which defines decompensation in cirrhosis. So it's one of the defining factors. And then you have HE associated with ACLF. So it makes you wonder at one point, if HE is on board first as a decompensating factor, can it play a role in ACLF involved in sort of the failure of other organs? The bidirectional point, I think, is important, and I think it's probably truthful. How much goes from top to bottom and how much goes from bottom to top, I don't think we know right now, but as you know, the brain is a powerful organ, so I think it definitely could have an impact on what's going on in the systemic circulation. If you understand that you have sort of an organ which is not doing very well, which is in the midst of dying within you, there's a lot of release of systemic factors such as oxidative stress and inflammation, and that could create an environment that could be even more toxic to ammonia, meaning that the ammonia toxicity can be amplified or modified depending on its environment. So having an elevated systemic inflammation could lead to susceptibility to ammonia toxicity. So I definitely think it plays a role. Whether ammonia and inflammation are independent or dependent factor is something we don't really know at this point. Hepatic encephalopathy, by definition, is associated with neurological dysfunction, liver disease, and an increase in blood ammonia. So we think those are the three parameters that are necessary if you want to create a new model or use existing models. What we don't have right now is the impact of etiological factors such as alcohol or fatty liver disease, steatosis, and even hepatitis viral infections. So the ones we have now are really just inducing liver disease by different toxins or by bile accumulation. And so we don't really have a model now to really show the impact or demonstrate the impact of the etiological factors, which I think is missing. And I think that's something that we have to really work on in the future. ISHEN, as the International Society for Hepatic Encephalopathy and Nitrogen Metabolism, fosters collaboration. It really assembles different people working in different parameters of liver disease and hepatic encephalopathy. We have hepatologists, gastroenterologists, basic researchers, and so forth. So our mission really is to advance the field on many levels. Research, fundamental research, clinical research. We're looking at diagnosis of hepatic encephalopathy, management of patients, and even talking about new treatment strategies that can help these patients in the future. As you can probably realize, hepatic encephalopathy is associated with liver disease and brain dysfunction. So we have most of these patients that are seen by hepatologists or gastroenterologists. So those are the primary, probably the majority of our society. There's also a lot of neurologists and psychologists that are interested in our field. We have nurses, primary care physicians. We have transplant surgeons who may be transplanting these patients in the future. So it's really, as you see, it's an expertise that's really within focus of hepatic encephalopathy, but broadens quite largely when you see where these patients are being seen and who they're being treated by. I think children who are born with a mutation within the urea cycle that leads to hyperammonemia is a little bit different than what we see in patients that have chronic liver disease. Both are associated with increase in ammonia. However, the children, as we know, are much younger compared to the patients that are much older. The children don't have liver disease per se, but they do have these hyperammonemic crises, which we also see in patients. But what's inducing this increase in blood ammonia is not maybe similar in both cases. In the children, it's not exactly sure why they get these hyperammonemic crises. It could be diet-induced, whereas they don't have these precipitating events that we see in cirrhosis. But coming back to the brain, a young brain versus sort of an older, mature brain, there could be some differences as far as compensatory mechanisms, and either the children with the young brains are either more susceptible or more resistant as compared to the adult patients that we see. Urea cycle disorders. In UCD world, they have much better treatments to lower ammonia than we do in cirrhosis. And they actually monitor ammonia very closely in these children as compared to what I think in cirrhosis. So they have glycerol phenylbutyrate, which are treatments that were actually really accepted by the FDA in UCD, which I think is, again, coming back to my point, we're missing in the cirrhosis world. We're missing a true ammonia lowering strategy, which we don't have. I think the future of hepatic encephalopathy is quite open, and I think there's a lot of unmet research gaps as far as understanding about ammonia measurements and also about monitoring ammonia. I think ammonia should be measured more often, not only in the hospitals, but actually at home. We don't have any idea whether patients who are living with cirrhosis at home have high ammonia. We understand that they come to the hospital with high ammonia, but we don't really know whether there's resolution as far as how long they've had hyperammonemia for and so forth. So I think there's a big need to understand the progression or natural history of hyperammonemia in these patients. I think it's also important to really dive deep into the heterogeneity of hepatic encephalopathy. There's a lot of systemic factors that can cause what we may think is hepatic encephalopathy, including ammonia, infection, and so forth. So I'm wondering whether we should be sort of clarifying HE based on its precipitating factor as opposed to just giving the umbrella effect on hepatic encephalopathy. I think for treatments moving forward, we should actually be treating the precipitating factor and not so much just treating hepatic encephalopathy. I think it's interesting that hepatic encephalopathy may be difficult to diagnose for the hepatologist, especially on the first-time visit. But when you have a caregiver that comes with the patient, I think you'll find out the caregiver may say something that, no, this patient is not normal and his attitude has changed or his behavior has changed drastically in the last couple of days, which will help the hepatologist to really further diagnose or to confirm that the patient has hepatic encephalopathy.